in the world. Welcome to our online conference today. Before giving the floor to our dearest guest, I want to introduce our team. I will be the moderator of today's conference. My name is Ayman Maydan. I'm a neurosurgery resident in Astana, Kazakhstan. These online education meetings have started with Professor Hasan Kamil Suçu, the residency program director of the neurosurgery department of İzmir Atatürk Training and Research Hospital in Turkey, and goes on with the contribution of all the residents, also the contribution of the neurosurgeons who graduated from the same department, and also neurosurgery residents and neurosurgeons from nearby countries like Bulgaria, Georgia, Ukraine, and Kazakhstan. All microphones will be turned off to prevent sound and noise pollution. During the speaker's presentation, you can ask your question not by turning on your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your question will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. Please don't ask for your microphone to be turned on. And now I would like to introduce our guest. It's my privilege to present our lecturer, Professor Peter Vajkoczy. And Professor Peter Vajkoczy is the full professor and chairman of the Department of Neurosurgery in Charité, Universität Medicine in Berlin, Germany. His clinical special fields of interest are neurovascular surgery like aneurysm, bypass surgery, AVMs, skull-based surgery, including pituitary and posterior fossa, neuro-oncology like complex glioma surgery, and minimal invasive spine surgery. His research fields are the pathogenesis and therapy of subarachnoid hemorrhage, the prevention and therapy of vasospasm, novel concepts of multimodality monitoring of neurocritically ill patients, arteriogenesis following vessel occlusion, cellular and molecular mechanisms of brain tumor angiogenesis, and mechanism of brain tumor cell migration and invasion, relevance of neuronal guidance molecules for brain tumor biology, as well as homing and recruitment of immune hematopoietic cells to the nervous system. Welcome again, Professor. Now you can start your screen sharing and your presentation, please.
So, Ayman, thank you very much for the introduction, and thanks to Hasan for giving me the opportunity to present here. Hasan has asked me to talk about bypass surgery in the brain, and since I would like to give you a detailed overview and not rush through all the topics, I will focus on ischemia and the indication for the different types of ischemia for bypass surgery. There are some new data, so it will be like an update also in certain aspects, and we can discuss what has recently been developed or identified. So number one, I would like to discuss with you the bypass surgery for atherosclerosis. This is certainly a controversial topic, but it's a very good introduction to the field of bypass surgery and the indication and also of the diagnostic workup. So the overall concept of bypass surgery for the brain is that you perform a bypass in order to get more blood into the brain. However, this makes only sense if you have a hemodynamic compromise of the brain. Most patients that have suffered from stroke usually have a thromboembolic stroke. And obviously for those patients, more blood will not be helpful. And there's a small subset of patients, 10% or 15% of patients, that have a high-grade stenosis, either at the extracranial or at the intracranial part of the carotid artery or along the M1 segment. And due to this steno-occlusion, the perfusion pressure is going down. And this is the group where a bypass really makes sense in order to deliver more blood to the brain. And then we have the small vascular lacuna infarcts, which are, again, not a good candidate for bypass surgery. So in the end, it's only 10 to 15% of all patients with steno-occlusive disease in the brain that really benefit from a bypass, or at least are candidates for a bypass surgery. And the question is, how do we identify these 10 to 15%? The single most important analysis is a functional CBF study. So first of all, you have the patient that has symptoms, maybe a stroke, maybe a TIA. Then you perform the diagnostic workup with the MR. The MR will show you maybe some border zone infarctions. Sometimes the MR, however, is without any signs. Then you perform an angiography and you will see the high-grade stenosis or the occlusion of a certain vascular segment. But then, to really make the diagnosis of hemodynamic compromise and really identifying patients as candidates for bypass surgery, you have to perform a functional CBF study for cerebral blood flow or cerebral perfusion. And here, it's not only important, or it's not important to identify whether the patient has a asymmetry under baseline. These patients usually have a very good baseline perfusion. However, the most important variable is to test for their reserve capacity. And the reserve capacity describes whether the patient is able, or the brain of the patient is able, to increase the delivery of blood flow in stress situations. And therefore, you have to mimic the stress situation. For example, by giving a drug, a pharmaceutical compound, which is called acetazolamide or Diamox, and they vasodilate the blood vessels, and then you will see an increase in perfusion. If, however, these blood vessels are maximally dilated because the patient is already borderline, then the vessels are not able to dilate, and we call that state a loss of the reserve capacity. So patients which have a maximum dilation of their blood vessels and have lost their reserve capacity, these are the patients that have a higher risk of stroke because they cannot adjust to stress situations like orthostatic issues, like lacking fluid because they have not drank enough, or because they are sweating too much if it's hot. And this is identified by PET or by SPECT. And PET, water PET with radioactive water, is the most sensitive way to identify those patients. And we have made a study compared to SPECT where we could show that we identify 25% of patients with the PET that we would have missed with the SPECT. So my former boss, Peter Schmiedek, was working on that topic, and he really was fostering and developing the concept of hemodynamic compromise, reserve capacity, and blood perfusion measurements. And here's one study where we have not been part, from the US, from St. Louis. Here are two groups. The green group is the patient group with an intact reserve capacity, and the red group is the patient cohort with a disturbed reserve capacity or loss of the reserve capacity. And you can see that if you have lost your reserve capacity after 2 years, the risk at that time was 30% to develop a stroke, while the risk was not increased if the reserve capacity was normal. This really shows you how important this assessment of the cerebral vascular reserve capacity, or CVRC, how important this step in the diagnostic workup is to identify patients which are candidates for bypass surgery. And if you perform the bypass, now this is from this is the increase upon stimulation. So if you have no increase upon stimulation, there is no reserve capacity. And following the bypass, already after 1 week, after 1 month, after 2 years, the reserve capacity is increasing and is normalizing. So if you give Diamox, you expect 10 to 20 mils per 100 gram per minute increase as a consequence of this stimulus. And this is normalized with the bypass. So the idea was that the bypass normalizes the reserve capacity and brings patients from the red group to the green group. Okay, I cannot advance. So recently, 2 studies have been performed to test this hypothesis that bypass is protective. Number 1 is the Japanese trial, the JET study, and this is the American trial, the COS trial. And I will give you a summary of both studies, and you will see the controversy in the field. The Japanese trial had included 200 patients, and here the reserve capacity was measured with SPECT, with an asymmetry index, which is the most widely spread technology. We have a 3-year follow-up, and the patient was positive. Bypass reduced morbidity and mortality and ipsilateral stroke significantly. And the COS study had included 140 patients. It's important to understand that this study was stopped prematurely because the enrollment was so slow. It took 8 years to include 140 patients. And here PET was used, and the mean follow-up was 2 years. And here there was no difference between the 2 groups after 2 years and after 3 years. And the reason why was that the bypass had a high stroke rate during the perioperative time. So while the surgery was performed, a significant number of patients sustained a perioperative stroke, and this led to this increase in the first days. But then the curve was pretty flat, while the patients that were on medical treatment developed strokes in a linear way. So the groups crossed after almost after 2 years. So there was no significant difference, but the patient group was never followed for a longer time. At least it was never published. And this was really the striking effect, that in this study, the patients had a perioperative stroke risk of 15%, which was much higher than previously in other studies previously recognized and published. Because all the other trials, the big study in 85, the cohort from Stanford, and our series, we all had perioperative stroke rates which were below 5%, which was much lower than the 15%. It's true that sometimes if you perform randomized controlled trials, complications are detected more frequently, but the difference between less than 5% and 15% was striking for everybody. And the explanation, and interestingly, in the JET trial, the perioperative stroke rate was 0%, which was on the other end, which was very low. And this was the reason why the JET study was never published in a very high journal, because nobody believed the complication rate of 0%. And if the COS trial would have had a perioperative stroke rate of 7%, the study would have been positive. So you can discuss why the surgeons had so many complications, whether it's whether it's the experience that they were lacking, whether there were too many centers, more than 40 centers involved. So there might be different explanations. On the other hand, the medical group was also doing better than expected, with a double platelet anti-aggregation with clopidogrel and aspirin. So surgery was doing worse, and medical treatment was doing better than expected. And this led to a non-significant result. Just recently, a Chinese trial aiming at carotid artery occlusion and bypass has been published in JAMA, and I would like to discuss that. 160 patients per group were included, and here again there was no significant difference between the surgical arm and the medical arm. However, you can see a clear trend that surgery did better, with a stroke rate of 8.6% versus 12.3%, but it was not statistically significant. What you always also see is, again, we have some perioperative strokes here, and then again, the flat curve. And the curves already cross after 6 months. And here, this perioperative stroke rate was significantly lower, which was very good for the study. Obviously, the surgeons were more experienced. And again, the medical arm was doing better than expected. So the lower perioperative stroke rate and the lower stroke rate in the medical arm suggested that this is maybe a patient cohort which is not so severely affected as the others studied before. And I have to warn you that the results of the study cannot be used to argue whether bypass surgery is beneficial, because this group has studied the wrong patient cohort. And the reason why is they have used the wrong inclusion criteria. So these were young patients, less than 65, which is okay. Unilateral ICAO and MCAO is also okay. This is the same as for the COST trial. Most recent stroke, more than 3 weeks, so patients had to be stable, which is okay. Neurological deficit stable, okay. Sometimes we have patients that have repeat TIAs or that have repeat strokes, and and obviously this group has been excluded. But the most important criticism about the study is that the group has used a CT perfusion at baseline only. So there was no stimulation, there was no testing for reserve capacity. And in the beginning, I've told you how mandatory these tests are to really identify those patients that a bypass would target. Here, the group has simply treated patients where the baseline perfusion was reduced, but this is not the patient cohort with the hemodynamic compromise. And this might explain, for example, if a patient had a stroke, the perfusion on the stroke hemisphere would be lower because the demand is lower, and this patient would have been revascularized, although the reserve capacity for the healthy brain most likely was maintained. So this was not a good candidate, and patients were included that the hypothesis is that patients were included which needed no bypass, the low-risk group. And this is why both the surgical arm and the medical arm did so well. So please don't reference this paper in order to argue for or against bypass in atherosclerosis. So there are other indications than stroke prevention. So some patients have limb-shaking TIAs, they cannot walk, they have repeat blindness on one eye temporarily, they have increasing numbers of frequencies of TIAs. Some of the patients not only have a unilateral, a single vessel occlusion, they have multiple vessel occlusions, and they have high-grade stenosis. And these groups and these patients all were not included in these studies. And we have recently published our patients that we have treated with a bypass with atherosclerosis. And what you can see is that more than 50% or 50%, half of the patients have multiple vessel occlusions. So they are more severely affected than those that were studied in the COST trial. We have recurrent strokes, so they are also not completely stable in neurological means. They are severely affected with more comorbidities, and 1/4 has bilateral hemodynamic impairment. So if we perform the reserve capacity, both hemispheres do not increase in blood flow, but stay blue. So these patients are more severely affected, and our perioperative stroke risk was 4% in this group. Here you can see our activities over the time, and here you can see that those patients that are treated by bypass today, and these are the patients that are referred to us by the neurologists, are way more severely affected than the traditional patients going into the COST trial and also going into the Chinese study. And we have multiple vessel occlusions in more than 50%. So this is an example. You have a occlusion of the carotid artery on both sides, and both anterior, both hemispheres are supplied only by the posterior circulation. So this is a completely different ball game than those patients studied in the previous studies. Here you can see examples of the hemodynamic studies. So here, all these patients had a reserve capacity assessment with a PET. Some had unilateral blue brains, some had bilateral impairment of the reserve capacity, and all of them were symptomatic. And we also included 20% of patients that were older than 70%. So this gives you an idea that we are not treating the classical COS patients. We are treating the patients that are referred to us by neurologists, and neurologists would never refer classical COS patients to us because the study in their eyes has been negative. And we are treating these days patients that are more affected. The bypass
I think his connection has gone. So yeah. Oh. Okay. Professor, your connection has gone, and
I'm back. Can you see me?
yeah, now you can share your screen again.
Okay, I will try. So now we should be back.
Yeah.
So messages, patients that we treat are more severely affected than the patients that have been studied, because neurologists only refer patients that are not COS patients, but that really need the bypass in their eyes. Okay, so, and then there is also the situation where it's not the classical internal carotid artery occlusion. Some of the patients have occlusion of the common carotid artery. This is relevant because then the external carotid artery is also occluded, and the bypass vessel is coming from the external carotid artery, as you know. We perform STA-MCA bypasses for these patients. So if sometimes the bifurcation is open, then we can perform a simple interposition graft from the subclavian artery to the internal carotid artery. If the bifurcation is closed or occluded, then we perform a bypass from the vertebral artery to M2 using a radial artery graft, as you can see here. From here, vertebral artery to M2. And if the patient has only one vertebral artery and we cannot justify to perform a temporary occlusion, then we would perform a long graft with a saphenous vein from the subclavian to the M2. So you see that you can also treat occlusions of the common carotid artery with different strategies. Now I'm wondering where okay, we have missed this one. So here I wanted to show you the classical STA-MCA bypass, which is an anastomosis of the STA with a superficial branch of the M2. Here you can already see the M4 segment. This is the bypass graft coming in. We are leaving a perivascular cuff in order to prevent spasm. And here we are suturing the end-to-side anastomosis with 10-0 sutures. And then we are performing an STA-MCA, and then we are performing the ICG showing the open anastomosis. So this is really the working horse. And all the other bypasses that I've shown you are reserved for more complex situations, like common carotid artery occlusions. And then you really have to go into the detail which kind of bypass you can perform. Sometimes there's also an occlusion in the posterior circulation. So, for example, you can have an occlusion of both vertebral arteries, either at the origin or until their way to the bifurcation, or you can have a high-grade stenosis of the basilar artery. And for either of these situations and locations, we can perform different bypasses. Problem is, it's more difficult to identify hemodynamic patients in the posterior circulation because the PET study does not really work in the posterior circulation due to the low spatial resolution. However, if from the clinical aspect, if you think that it's a hemodynamic problem, you would revascularize the lower posterior circulation with a bypass from the occipital artery to the pica, or with a radial artery from the vertebral artery to the PCA, or to revascularize the basilar tip, for example, you can perform an SCA to PCA or occipital artery to P3. So there are different ways. Usually we like to use the radial artery from M2 to PCA through a trans-Sylvian approach. But this is just to give you an idea about the different bypasses that we can use. So this is the most frequent that we use. We take the occipital artery and then swing it over and perform an anastomosis to the pica. And this is what I mentioned, the radial artery from M2, trans-Sylvian subtemporal to the ambient cistern going to the P2 segment. And this will revascularize the posterior circulation. Example, the left side has been occluded of the vertebral artery. This is a segment that has been treated with a stent. There was an in-stent restenosis. The patient became symptomatic again. And we have performed an occipital artery bypass to the pica, as shown here on the other side. And this occipital artery is now filling the whole basilar artery. Or this bypass with the radial artery graft, we go to the M2, first anastomosis, and then simply intradural, subtemporal, go to P2 and perform the graft. So here you can see the M2, this is the proximal anastomosis done here. And then this is the radial artery graft, subtemporal approach to the P2 segment. And this is the distal anastomosis. So basically we are creating a new PCOM from the anterior circulation to the posterior circulation. And what we have currently started is we have started a randomized trial. We'll use the same patients that we have reported, and we are randomizing the patients between bypass and medical treatment. And this is a single center trial, like the BRAD trial. So it's only in one center. We are getting the patients from everywhere. One team is performing the surgery, and we are aiming at 70 patients in both groups, and the patients will be included based on their PET studies, and the age is less than 80, and then they will receive their bypass, and we'll see whether bypass is maybe superior in these patients that are well defined and more severely affected. And we've already recruited 10 patients, so it will take us like 5 to 8 years to recruit the patients, and then we will see. So for atherosclerosis, we can say the results are controversial because of the studies that have been negative. The most important variable that is influencing the success rate is how safe is the surgery, how high is the perioperative stroke rate. If it's less than 7%, bypass might be beneficial. The bypass patients are more severely affected that we are treating today. And there are multiple other indications, and we have started the trial. So now I would like to focus on another indication, which is moyamoya vasculopathy. And this is a completely different story because the vascular biology is more complex and less well understood. There are multiple occlusions, and bypass is clearly without discussion playing a role for treatment of moyamoya patients. So these moyamoya patients are characterized by multiple occlusions along the intracranial internal carotid artery and M1 and M2. And as a compensation, these patients will develop these typical collateral blood vessels, which are typical for moyamoya. And moyamoya in Japanese means puff of smoke. And you can understand why it's called puff of smoke with all these collaterals. Typically, it's bilateral on both sides. So there are three hallmarks. Number one is the occlusion, and this is why their reserve capacity is also reduced. Number two, these patients have a higher vascular plasticity, and this is why they are able of performing all these collaterals. Patients with atherosclerosis are not able to induce all these collaterals. And number three is the blood vessels they form are still fragile, and they tend not only to develop strokes, but also to develop hemorrhages. So although they are capable of inducing all these collaterals, these are not really mature blood vessels. They're always prone to rupture and to cause hemorrhage. Moyamoya vasculopathy, or today we say moyamoya arteriopathy, just describes the phenotype of the blood vessels. If these blood vessels are the sole disease, the main disease, then it's moyamoya disease. Sometimes these vessels come with other diseases like Down syndrome, like have received radiotherapy for a craniopharyngioma. Then it's a moyamoya syndrome because the moyamoya blood vessels are part of a syndrome. And it's a big difference between disease and syndrome. It's a rare disease. Even in Asia, the incidence is less than 1 per 100,000, and in Europe, it's 1/10 less frequent. Females are more frequently affected, and there are two peak ages: a pediatric group and a young adult group. There is some genetic background to moyamoya. Some of them seem to have a genetic familial background, and if in the families where moyamoya arteriopathy or moyamoya disease is more frequently, these patients are younger and the disease is more aggressive. However, many factors have been discussed as being responsible for moyamoya disease, but it's still not clear which of these factors is really involved in the disease, and we have just written a review on the genetic basis. And this is the different signaling pathways, which just gives you an idea about the complexity of the underlying signaling pathways of moyamoya disease. So this is our experience. Meanwhile, we have more than 400 patients. Most of them are Caucasians, and most of them have moyamoya disease, but there's also, especially in the pediatric group, a significant number of patients which present with moyamoya syndrome. And this allows us to characterize the moyamoya population. So moyamoya disease is more frequent than the unilateral manifestation. Meanwhile, unilateral moyamoya vasculopathy or arteriopathy is also moyamoya disease, unilateral disease. It was a matter of discussion, but there are also atypical cases. And this shows us that in our series, the North American series and the Asian series, there's a difference due to the gender preference. So our series is clearly preferring the female gender. However, in the Asian population, the difference between male and female is not so obvious. And the frequency of unilateral disease is comparably between 10 and 20%. There are the two age peaks, the pediatric population and the young adults. There is no difference here between the different populations. How do they present our patients? Pediatric group, adult group. Most of the patients present with ischemia, as you can see here, both for pediatric and for the adults. And some patients, 10%, 8%, present with hemorrhage. And then, especially in the pediatric group, there are patients that have a retarded development, that have cognition problem, concentration problems. Suddenly they stop speaking. They're not able of improving with their language if they're very young. So these could all, and some have also epilepsy, seizures. So these are rare manifestations of moyamoya in the pediatric population. In the adult population, it's mainly stroke or hemorrhage. However, the frequency of hemorrhage differs between the different ethnic backgrounds. So here is adult, here is pediatric. And if you look to the Asian population, the adults would have 1/3 of the patients would have an hemorrhagic manifestation, which is more frequent than in our series. In contrast, in the pediatric population, hemorrhagic manifestation is less frequent than in the Caucasian population. So there seem to be also some differences with the ethnic background, and I'll come back to an analysis regarding the hemorrhage. The posterior circulation is less frequently involved, as you can see here. Only 1/3 of the patients have an involvement of the posterior circulation. And then we have the moyamoya syndrome. These are the different diseases which are with which the patients present if they have moyamoya syndrome. And you can see Down syndrome, you can see neurofibromatosis and so on. With moyamoya syndrome, again, pediatric group and adult group. And how do they present? The moyamoya syndrome patients, again, with ischemia. No hemorrhages here, a few hemorrhages here. But in the end, it's again ischemia or hemorrhage. And some patients have seizures and cognitive issues. And here, there's the difference between the different ethnic backgrounds is not as striking if it comes to hemorrhage as in the moyamoya disease group. So it's important to look at the PCA, the posterior cerebral artery. If this is involved, this is prognostically unfavorable because the posterior circulation is also an important collateral. And if the posterior circulation, the artery, the posterior cerebral artery, the PCA is also occluded, then an important collateral is lost. And here is the relevance of PCA involvement. Also in this study, in European group, it's 1/3. And patients progress to PCA occlusion if they did not have one initially within 5 years. And it's really a risk factor for the stroke. And the stroke risk is higher, 67% versus 15%. So it's really important to analyze carefully and to follow up these patients whether they develop PCA stenosis and PCA strokes. And here we have recently performed an expert consensus statement, which is saying that these patients should be really followed up to identify delayed PCA occlusions or PCA involvements, because these patients are at higher risk of stroke. And if patients have a PCA involvement, they need another bypass to the posterior circulation. So what's the underlying pathophysiology of moyamoya disease? Basically, the vessels are, the lumen of the vessels is getting smaller. And this is due to a hyperproliferation of the intima, of the endothelial lining. And this slowly, gradually leads to a scarring and occlusion of the blood vessels. And the underlying mechanism, as I mentioned, is not well understood, but that's the morphology to it. And as I've mentioned, moyamoya patients have a plastic vascular system. They have all these collaterals, and atherosclerotic patients have a quiescent vasculature. They have no collaterals. And when we treat the moyamoya patients, we take advantage of this increased plasticity and their capability of inducing vessel growth. So how do these collaterals look like? So a very frequent collateral from the posterior circulation is the callosal collateral. If you see a callosal collateral, that means the posterior circulation is feeding the anterior circulation through a retrograde perfusion in the distal ACA, pericallosal artery, then this is already pathognomonic for moyamoya disease. If you see a picture like this, this is a pericallosal anastomosis with moyamoya. And this is only in moyamoya disease and very rarely in atherosclerosis. At the same time, you can see an increased vessel density on the surface. So this is a moyamoya brain, this is an atherosclerotic brain, and you can see there are more blood vessels. And if you quantify them with fluorescence angiography, the vessel density is higher in moyamoya than in atherosclerosis. And this is another important aspect of moyamoya disease. The plasticity is so high that some patients even develop collaterals from outside the skull. So this is the STA, which is growing through the sutura into the brain and is contributing to the anterior circulation. So this just shows you that the need and the hunger for new blood vessels in moyamoya brains is so high that blood vessels even grow into the brain from outside the skull. And this is another example. The other one was the middle meningeal artery, and this is the STA, where you have a collateral blood vessel growth. So let's go to the hemorrhagic type before we go into the surgery again. So as I mentioned, there's a difference between the frequency in the Asian population and the Caucasian population. And the reason why are the different collaterals. So this is a study, this is the JAM trial. And the JAM trial was a randomized controlled trial, which had shown that bypass in hemorrhagic types prevents further hemorrhages. So bypass protects the patient from hemorrhages. And with this large patient population, they have analyzed the differences in the hemorrhages. And only patients with posterior collaterals from the posterior choroidal and from the PCA will develop hemorrhages. Those with the anterior collaterals, they are not at risk of developing another hemorrhage. In other words, there are different collaterals coming from the different basal arteries, which carry different risks of hemorrhage. The posterior ones, thalamic or choroidal, have a high risk of hemorrhage, and the anterior ones have a low risk. And the reason why Caucasian patients have a lower incidence of hemorrhage than the Asian patients is because they have differences in the collaterals. The Asian population has more posterior collaterals, and the Caucasian patients have more anterior collaterals. And this explains the difference. And this was shown by us in this paper. And then, as I mentioned, there is a difference in the fragility, and I'm not going into this. So let's go to the surgery. So again, we would perform a PET study, and the PET study would show us the loss of the reserve capacity, either on one side or on both sides. So this is a patient on one side. This is a patient on both sides. So in the end, it's the same diagnostic workup that we would do for atherosclerosis. And again, you see that the baseline perfusion looks normal. So this patient would not have been included into any of the trials, apart from that the fact that it's moyamoya, but it shows you how important the stimulation with diamoxis and the reserve capacity. So we have categorize the patients with the idea to have to stratify or to predict the risk of surgery. And 3 independent variables add to this grading system: the type of the collateralization, the severity of the ischemic attack, and the degree of the hemodynamic compromise. And then we have 3 grades: grade 1, grade 2, grade 3, mild, moderate, and severe. And this allows us to categorize the patients and to predict the risk of their surgery. So, for example, here you can see grade 1, grade 2, grade 3. And in our study, the risk of ischemia, the perioperative stroke risk, was 0%, 8.5%, 16%. So patients with grade 3 have a higher risk for surgery. This is important to counsel the patients, but you would also like to operate the patients early on when they are grade 1, then wait until they are grade 3, because the risk will increase. So this classification has been validated. We have started the classification with xenon CT. Here it's validated for PET. But more importantly, it was validated by the Japanese group, by Kuroda. He showed the same thing. The risk goes up for the surgery with the grade 3, especially the grade 3 were the ones that had complications. And also the Steinberg group has validated that patients with a grade 3 have a higher risk for complications than patients with a grade 1. So grade 1 blue bar is doing better than the other bars, and it's in some way linear way how they are doing worse, depending on the grading system. So first we do the analysis, then we grade the patients, and then we operate the patients. And there are different techniques. There's a direct technique, that's the bypass that you've already seen. And then there are indirect techniques. The indirect techniques only work with moyamoya patients, and we place something on the brain that is vascularized, and due to the collateralization, new blood vessels will grow in and will supply the brain. So this is why it's called indirect, because we are not performing a direct connection, a direct anastomosis. We just place a flap on the brain of muscle or of dura, and then new blood vessels will grow into the brain. It takes more time, and it's a revascularization that takes like 3 to 6 months. And the discussion in moyamoya patients is always, is it direct or is it indirect, or is it a combination of the two? So when you read the papers or when you counsel patients, it's always direct, indirect, or a combination. Apart from that, there are multiple variations. So the principle of the direct revascularization is that it's a direct anastomosis. It's technically more challenging. You have a good patency rate, and the big advantage is you have an immediate flow protection. Immediately, the flow will improve. And this is the STA bypass. Sometimes we take the frontal branch, then we make one incision here, a second incision here, and the branch is subcutaneously transposed to the craniotomy. Meanwhile, we perform a small craniotomy at the end of the Sylvian fissure. And if it's the parietal branch, we would do one skin incision and then extend a little bit to the back and perform the craniotomy. So this picture shows you that meanwhile, we are performing a minimally invasive approach with a small thick craniotomy at the end of the Sylvian fissure. However, sometimes you have to revascularize the MCA and the ACA territory with the 2 branches of the STA. So you have a frontal branch and a parietal branch. And then we would perform, we would use the frontal branch for the ACA, and we would use the parietal branch for the MCA territory. So this is a double barrel bypass. Or we use a long graft, and then we not only perform an end-to-side anastomosis here, but also take another branch and perform a side-to-side anastomosis. So the first anastomosis is the side-to-side anastomosis. This will be the first anastomosis. And then we have an end-to-side anastomosis. And with these two anastomoses, we can use one graft to revascularize different areas of the brain. So this is sometimes necessary because you might have an occlusion of the M1 and you might have an occlusion of the A1, and then you have to revascularize both territories. Sometimes we are also using radial artery. So we are taking or harvesting the radial artery from the arm. This is especially for revision cases. And then we go to the neck. We perform the anastomosis in the neck to the external carotid artery. Then it's subcutaneously tunneled. We go to the Sylvian fissure and we perform an anastomosis to the Sylvian fissure or to a M3, M4 branch, depending on the size. And this is a good technique for revision cases. Or if we have to revascularize the posterior circulation because the patient has a PCA involvement, patient is positioned on a supine position, a prone position, the occipital artery is mapped out with ultrasound or with navigation. And then we would perform an opening here, and we have the occipital artery, and the occipital artery is then mobilized. We perform the craniotomy, and then we perform an end-to-side anastomosis at the posterior circulation to a distal PCA branch. So more variations than with arteriosclerosis. And then is the indirect revascularization. So the indirect revascularization is placing something onto the brain and waiting that blood vessels grow in. And this takes some time. And there are different ways to do that. Number one is an encephalomyosynangiosis. You can perform a pterional craniotomy. You spare the middle meningeal artery because this is sometimes involved, as I've shown you, in the collateralization. You can see the red brain with many blood vessels. And then encephalomyosynangiosis means that the temporalis muscle is placed on the surface, shown here, and then the bone is placed onto the muscle, and we have some space here to allow the muscle to pass by. So this is a straightforward surgery. You just place muscle on the brain. However, it takes some time until the revascularization takes place. And this concept of placing muscle or gallia can be performed everywhere on the skull. For example, you can perform a bifrontal craniotomy and place the gallia onto the brain. In the end, this is for the revascularization of the the ACA, the anterior cerebral artery. And the same can be done with a temporalis muscle or in the posterior circulation. And there are different techniques. You have seen the EMS. This is the encephalomyosynangiosis. The EDAS is just flipping around the dura. And then you can combine all of these. And without going too much into the detail, this just shows you the large variety of the different ways how to revascularize the brain. In contrast to atherosclerosis, there is no discussion that bypass surgery is beneficial for moyamoya disease. Number one, the stroke rate is much higher. Number two, the hemodynamic compromise is more severe and patients are more effective, and it's a progressive disease. And patients improve by bypass surgery. And at least for hemorrhage, we have a positive RCT, which is the JAM trial. So the next is the discussion, what is better, direct or indirect? And there are different meta-analyses that have looked, and we went through all these studies when we established the European guidelines. And in the end, the direct bypass is beneficial then compared to the indirect bypass. So whenever feasible, a direct anastomosis should be performed. It can be combined with some indirect, so it's a combined, but direct or combined is superior to indirect. And this is also true for pediatric patients. So in children, you might go with indirect alone. However, it should be it should be always combined with a direct anastomosis. So, for example, this is our technique for kids. For kids, we are performing a craniotomy, like for a pterional craniotomy. Here you can see the large opening. We have performed the bypass, the anastomosis. Then the dura is flipped around, and encephalodurals and angiosis is performed. And then we place the muscle onto the brain. And this is the combined technique for kids. Large surface, multiple indirect techniques combined with a direct bypass. And this can give you a picture like this. However, sometimes the muscle is doing well and the bypass is not so strong. And sometimes the bypass is strong and the muscle is not doing so well. So what's the difference between these two patients? The one is a pediatric patient and the other is an adult. This is to show you that the success rate of indirect techniques is depending on the age. In adult patients, indirect techniques do not work well or not sufficiently. And in pediatric patients, the indirect techniques work better. However, you should always back them up with a direct anastomosis. Okay, and this is what I mentioned. Here again, the direct or combined is doing better than the indirect. And the same is true, and this is the complication risks, the risks for stroke or disability. It's the same. So the indirect is not safer than the direct. So you should always try to combine it. So what are we doing? This is our patients. So you will very rarely find that we are performing indirect techniques alone. We usually combine them, the bypass, the direct bypass, with some kind of indirect technique, and rarely again direct alone, more frequently in adult patients. So bottom line, we always try to go for a combined technique. This is the combined technique for kids. I've shown you already through the pterional craniotomy. And what we have started years ago for the adult patients is to perform a combined technique through a minimally invasive approach. So again, the small craniotomy at the end of the Sylvian fissure, then the bypass, and then we flip the dura around, encephalodurals and angiosis, and we could show that this small flap, although the flap is very small, gives you quite a good revascularization. So it takes some time. Here, this is high, this is moderate. So you should look at this group, and this group is increasing over time. But already after 3 to 6 months, some of the blood vessels have sprouted into the brain. And this is a very good backup, which is sufficient. You don't have to go for a big craniotomy in adult patients. And it should always be combined with a bypass, because the bypass from the beginning gives you a good result in more than 40%, and more than 50% of the patients. And both in combination give the best result. So sometimes the bypasses fail, either angiography or hemodynamically or clinically. It's important if you have a patient that is becoming symptomatic again, and the perfusion measurements shows that the patient needs a bypass again because the reserve capacity is again blue, then we have to go for a redo. Sometimes because the bypass did not work, and sometimes because the disease has progressed with the PCA, a new stenosis at the PCA. So this is our series. It's very rare. Only 4% of our patients need a redo bypass. So it's a rare situation that the bypasses fail. And these are the different strategies that we have used initially that failed. Most of them are the minimally invasive bypass plus the EDS, the encephalodurals and angiosis. And then we have some other combinations. And usually they fail with our minimally invasive approach. So why do we have to revise? Because patients are symptomatic, or because the surgery could not be completed, or they have a secondary P2 occlusion. So there are classical technical failures. The anastomosis didn't work, or the bypass occluded. And this can happen at any time. So the occlusions can also happen up to 6 years after the initial surgery, or this is the occlusion of the P2 segment of the progression of the disease. So revision surgery is not something that is early after the bypass. Bypasses can fail over the time. So it's important to follow the patients up. So when we have to do a redo, the first surgery was usually performed with a small craniotomy at the end of the Sylvian fissure. And the second surgery usually will go with a pterional here. So we have enough space for another craniotomy. And if there is another STA branch, we would go for another STA anastomosis. Sometimes the other STA is still available. And this is shown here. We have the small craniotomy here. We perform the second craniotomy, the new craniotomy. So the other one is back here. This is the new one. And then we have multiple recipient vessels, and we are using the other STA branch for the anastomosis. And we might combine it with some indirect techniques in the pediatric patients. For example, this patient here, typical classical moyamoya in an adult patient, received the bypass that was working well. Bypass working well here. And then the patient was undergoing some kind of orthopedic surgery. The aspirin was discontinued for only 2 weeks, and the bypass occluded, and the patient was symptomatic again, and the PET was blue again. And then we performed the technique that I've shown you with using the other STA branch, and this resulted in another nice bypass that again protected the patient. But there are also patients that where there is no other STA branch, and then we have to go for the radial artery. I've shown you before the concept of the radial artery graft. This is the patient here. This is the patient with the bypass that was initially performed. Then it failed. And then we performed the radial artery anastomosis here. And then we have a nice revascularization with the radial artery graft. And if the patient progresses with a P2, then the occipital artery comes into play. I've shown you already the concept of the bypass with the occipital artery. Occipital artery is used, and then we look for a distal branch of the PCA in the occipital area from the interhemispheric fissure. And then we perform again a direct anastomosis using the occipital artery. And this typically happens if the posterior if the PCA occludes, like in this case. Here you can see the early study of the patient in 2016. Both PCAs were open, and then patient was becoming symptomatic, and then suddenly the right PCA was occluded. So this is a patient where we would perform the revascularization using the occipital artery. And then we can combine it, and then you see that all these techniques that I've shown you can be used for the redos as well. So our favorite, however, is using the radial artery graft in 60%, and all the others are rarely performed. So we like to go for the radial artery if the initial surgery did not work. So this is the workup. Did the bypass initially work well, or is the graft function insufficient? If the graft is not working, then we would check for the second STA branch. If there is no second STA branch, we would go for radial artery. And if there is no radial artery in moyamoya, then we would go for an indirect technique alone, muscle or gallia. And if the graft functions well, but we have a progression with a P2 occlusion, then we would do the posterior circulations that I've shown you. So this is the workup. So moyamoya, I've shown you the epidemiology of European patients. I've shown you the grading system that we are using and which identifies the high-risk patient. And we use that as an argument why we first revascularize the symptomatic hemisphere, and we would then revascularize a few weeks later the other hemisphere, which is less symptomatic or asymptomatic, because it's a good grade hemisphere with a low risk for the surgery. And it's important also for you as the audience, for the pediatric patients, it's also important to revascularize both hemispheres if they show the typical signs of moyamoya. Then it's important to rely on a direct anastomosis and to really go for combined techniques and not only place muscle on it or make some burr holes. So we should always go for a combination with an indirect technique and a direct bypass, also in the pediatric populations. So I thank you for your attention, and I think I've given you the whole overview, what is known for bypass in atherosclerosis and bypass in moyamoya, and I'm happy to take some questions from you. Thank you for your attention.
Thank you very much, Professor. It was a wonderful lecture, full of best knowledge you can provide to us for persons who are still learning, and we're eager to learn from you even more. There are several questions on the chat. How important is a FT?
How important what?
Is a PET scan after the bypass has been placed? I have the impression that this is handled differently depending on the clinic. Are there equivalent alternatives to the PET scan as a follow-up examination? I'm not a specialist, but have moyamoya myself, and saw the Zoom link on Professor Vajkoczy's Instagram account and was interesting.
Yeah.
I hope this is okay. He's from Germany.
So the PET is important to identify the patients that need the surgery before the surgery. If the surgery has been performed and the bypass is open, and this has to be controlled by angiography or by CTA, if the bypass is open and the patient is doing fine, then the PET study is not important for follow-up. So we do not follow up patients when they have no problems with PET. We only perform the PET if the patients come back a few years later and report that they have stroke again, or TIAs, or if they have other symptoms like epilepsy again. Then the PET is important to see whether the bypass is still working properly.
Okay, thank you very much. Medical student from Mexico, Jose Piebrick, is asking what is the percentage of failure of revascularization when AMS is done in an adult patient, or what defines a good radial artery graft for redo? Are radial artery grafts more likely to work in infants, or annual checkups must be done until 6 years after surgery? Thank you for the invitation.
The percentage of failure of an AMS in adult is much higher than in pediatrics. So in adults, only 50% or only 30% will show blood vessels growing in, but they never contribute enough to reverse the hemodynamic reserve. So if you have a patient, if you have a patient with atherosclerosis, AMS does not work at all. If you have a patient with moyamoya, who is adult, then the indirect techniques will contribute, but they will very rarely be able to normalize the reserve capacity. So the take rate is approximately 50%, and the success rate is much lower. In the pediatric populations, the take rate is 90%, and the sufficient contribution is approximately 50%. So the message is that if you see some blood vessels growing in angiography, this still does not mean that the blood flow coming through these vessels is enough. And this is why you should combine it. And radial artery graft is only for the backup, because another threat in moyamoya is that you deliver too much blood. And if you are using large caliber grafts like radial artery or saphenous vein, the risk is high that you have a hyperperfusion hemorrhage. So we try to avoid radial artery if possible and go with the STA. And the only indication is really a redo if there is no STA available. And then the radial artery is sutured to the cortical M4 in order to reduce the blood flow and not risk hyperperfusion. And checkups is not changing, whatever vessel you use. Every patient should be checked up at least with with MR and clinically.
Surgeon Javier Degollado from Mexico City is writing, thanks for the lecture. My question is, if you don't have the STA is done in both cases, MMD and atherosclerosis, what donor do you use?
Radial artery.
Can we use in place of superficial temporal or maxillary artery, for example?
Yeah, you cannot use the maxillary artery as a blood vessel to revascularize the brain. You can only use the maxillary artery as your for your proximal anastomosis. Then you have to go transtemporal, isolate the maxillary artery in the soft tissue, and then perform an IMAX anastomosis. That means this is the proximal anastomosis. However, if we are going with our small craniotomies, we don't get to the temporal base. And this is why I prefer to still use the external carotid artery as the proximal anastomosis. But you cannot use the maxillary artery as your blood vessel for performing the anastomosis or the bypass. It's just where the bypass takes off.
Thank you very much. Antonio Spinello is writing, thank you for the amazing presentation. I'm Antonio Spinello from Canton Spital, St. Gallen, Switzerland. First question, would you consider encephalomyodurosynangiosis as standard in addition to direct bypass in patients with impaired cerebral hemodynamics? And the second question, when would you consider a bypass in a patient with an M1 occlusion and persisting of symptoms despite medical therapy? Would you also base your choice on perfusion CT scans?
So number one, I would consider encephalomyodurosynangiosis. That means placing muscle and flipping the dura plus STA bypass as the treatment of choice for pediatric patients. In adults, since the indirect techniques are not as successful, we would perform the mini craniotomy at the end of the Sylvian fissure, do the bypass STA MCA, and flip the dura around, and mainly rely on the direct anastomosis. So it depends on the age. And if we have a patient with a M1 occlusion, then it's the same thing. We would not go for CT perfusion. We would go for SPECT, or we would go for water PET, perform the hemodynamic assessment, and then the bypass. This is for the chronic. I'm not sure whether Antonio means chronic or acute. Sometimes you have an acute occlusion of the M1 and it cannot be recanalized by endovascular means. Then obviously you go by CT perfusion to demonstrate the mismatch, and then you can perform a direct bypass. But this is completely different. Acute ischemia is completely different from chronic ischemia.
Okay, thank you very much. Sahin Hanalioğlu is writing, thank you for this excellent talk. What is your strategy for MMD with ACA dominant pattern? He's from Hacettepe University from Ankara.
Yeah. So there are two different philosophies. Number one philosophy is that, as you have seen on the surface, they have so many blood vessels and so many collaterals and so many interconnections. One part of moyamoya surgeons argues that the collateralization, the leptomeningeal collateralization on the surface of the brain is so good that you can just perform a bypass to the suprasylvian MCA territory, frontal area, and the blood will also take care of the ACA territory. And the other part of the moyamoya surgeons would say that you have to perform a targeted revascularization. That means make an anastomosis to the anterior, to a branch of the ACA, and some kind of indirect technique to the ACA. So what we are doing is, if we have a combined MCA-ACA type, we rely on the collateralization, make a good bypass, suprasylvian, and then see what's going to happen. And if the patient on PET is still positive for the ACA, then we would do another surgery. If the patient has a pure ACA ischemia because he has or she has an A1 occlusion or a high-grade stenosis at the A1, then we would take the STA frontal branch if it's long enough, and perform a direct anastomosis, which works usually. And if it's not working, then we would go for an indirect, especially in pediatric. These are usually pediatric patients, and we would perform an encephalodurosynangiosis with the gallia and with the dura at paramedian, using the frontal frontal flap.
Hey, Professor, may I ask my personal question? 2 years ago, we had a pediatric moyamoya patient, and we performed indirect bypass. He's about to rehospitalize tomorrow. Clinically, he had hemiparesis, and which is not deteriorated, but had not become any better. And eventually, he has some neurological deteriorations, loss of speech control. And is it your advice to perform direct bypass surgery for such a case?
I'm not sure what you have done as an indirect technique, but the drawback of the encephalomyosynangiosis is that if you have the muscle on the brain, this covers the whole sylvian fissure, and the muscle is stuck to the brain, and you have the blood vessels flowing in. So following an indirect revascularization with a big flap, it's usually very difficult to perform a direct anastomosis. So the only thing you can do is maybe go for a radial artery, make a big craniotomy, and see whether you find some kind of branch on the surface where you can still connect to. So that's a very difficult situation. Failures after indirect are difficult, very difficult.
Okay, we used a graft and sutured it to PM matter.
Yeah, so that it will be stuck, and if you remove the muscle, you will damage the whole cortical surface and the perfusion. So you have to find something around as a recipient, which is very difficult sometimes.
Okay, thank you very much.
Ayman,
Excuse me.
sorry, Madonna want to ask by herself. She is one of our international moderators, you know. So
Okay, please, Madonna.
Thank you very much. I would like to take a moment first to extend my sincere gratitude for a spectacular lecture, Professor Vajkoczy. Thank you for sharing your expertise. And as a young neurosurgeon, I find your insights truly invaluable. And on behalf of our diverse audience, I thank you for sharing your experience. As to my questions, I have several questions. First, with regard to indirect revascularization, you put the muscle graft directly on the brain underneath the dura, and then you put the bone flap, as I understand. Does it it makes sense why would it work in the pediatric population compared to the adults, but in a long term, in the long run, does it like, how safe is it? Does it increase seizure threshold and epilepsy? Are those patients treated with the anti-epileptics, or like, I'm interested in that aspect, but because like I would assume it would compress the brain and cause a chronic irritation, right?
Yeah, no, interestingly enough, in the chronic situation, they usually have no complications. So you don't have an increased epilepsy rate. In the acute situation, when you have mobilized the muscle and you have injured the surface, the fascia of the muscle, then you can observe some intramuscular hemorrhage, which might be space occupying, especially if the bone flap is put back. So it's rather the acute situation where you might experience complications, but long-term or mid-term, there are no complications due to the indirect technique.
Wow, that's very interesting. Thank you. And another regarding PET scan, I think there was a question in the chat from the patient, and from someone coming from developing countries. We don't have that much availability. It's not funded by the government. What are the alternatives? And like, does it conventional MRI angiography or DSAR enough, like evaluating the blood flow preoperatively and evaluating after the surgery? What do you think? Is it PET and SPECT absolutely must? Yeah.
For atherosclerosis, it's an absolute must. And you can either use a SPECT, which is, I think, available in most countries, or you could use breath holding MR, which has been recently suggested by the Zurich group. Then you basically hold your breath, CO2 is increasing, and this is the stimulus. And then you make the perfusion measurement on the MR. And this has been to some extent been validated against classical techniques. So I think, and then obviously you have Doppler, but Doppler is really only a screening method. But you have to find a way how you assess the reserve capacity. Just going by baseline does not work. And MR perfusion is not validated. So if at all, you should go for breath holding MR. Yeah.
Thank you so much. And last question, as for young neurosurgeons like myself, what advice would you offer in terms of honing our surgical skills and knowledge in the cerebral revascularization? Because like how to stay updated and how to stay in the course of the latest advancement in this specialized field.
Yeah, we have to be fair. I mean, the content of this talk was a very niche content. It's a very rare diseases with rare indications, and although we are performing approximately 100 bypasses per year, I would say that most centers either don't see the patients or do less than 3 a year. So it's something that in the end you should regionalize, or something that it's really not like disc surgery or spine surgery or glioma surgery. On the other hand, performing the anastomosis and learning how to handle the blood vessels, this can be done on a cadaver, or you can do it on a placenta, for example, or you can use chicken wings or plastic tubes. This really trains your skills as a microsurgeon. So even though you're not aiming at becoming a bypass surgeon, or if you're not aiming into going into vascular at all, performing these anastomosis is still a good way to train your hands and your capabilities. So I would suggest that everybody goes to the lab, uses placenta or chicken wings, and then you will see how you can excel your microsurgical skills.
Thank you so much. Thank you.
Okay, Ayman.
Ayman?
Dr. Shahin Hanalioglu asked another question: how to interpret the recent paper published in the GNNP Authors El-Nami et al. Direct versus indirect revascularization for moyamoya, a large multi-center study. They found similar success rates for direct and indirect, on the contrary to the existing literature.
It's an interesting study, but what always happens with direct versus indirect is that they are never randomized and they are never from one center. So usually some centers have an indirect approach, others have a direct approach, and then the results are compared, and it's not really controlled and randomized. So it's another study that can be added to the meta-analysis, and as long as the meta-analysis show that direct and is superior to indirect and the risk profile is comparable, I would always try to attempt, even in light of one study showing that they are similar. I think one study showing that they are similar does not justify to not perform a direct anastomosis. I mean, you can just perform the direct anastomosis and then you are on the safe side.
Thank you. Dr. Uday Gupta is writing, great seminar, sir. Thank you. Giovanni Ricci is also thanking you. The patient one asks again a question. I have a quick question about diagnostics. Is a PET scan necessary if it becomes apparent after the bypass that the vessels on the other side, non-operated side, are also narrowing? In other words, is the diagnosis for the second side carried out from the start, because the reserve capacity for the non-operated side can also deteriorate with the occurrence of stenosis?
Yeah, absolutely. So if you have if one side was operated and the other side was not showing any changes, and then over the course you develop changes on the other side, then the PET becomes relevant again to identify the time point when a bypass makes sense.
Okay, and what about if the patient has simultaneous posterior and anterior moyamoya symptoms? Do you first treat posterior circulation or anterior?
I would treat first the anterior circulation, and this might reduce the stress on the PCA. That is then maybe not necessary. And then I would observe whether the patient still has problems with his PCA, and I would then, if necessary, perform the PCA revascularization in a delayed way.
Okay, and what is your angiography rate after direct or indirect bypasses in pediatric and adult patients? How often do you ask for angiography after the operations?
In moyamoya patients, we perform an angiography after 3 months, after 1 year, 3 years, and 5 years. But I think this is in some extent because we are studying them. This is part of our protocol. But I think if you have demonstrated a functioning bypass, you could follow up the patients also with MR angiography, and you will see whether the bypass is working, and you would perform an angiography only if the patient becomes symptomatic or if things are unclear on the MR. But as I mentioned, we have a strict protocol on DSA still.
Okay, thank you very much. And Dr. Nurullah Kusmene writes, thank you, Professor. It was a great lecture. She's from İzmir.
Thanks for having me.
This was a great question with almost 80 participants.
Also, Mariam from Georgia wants to speak by herself. She's a medical student in last year.
Hello, first of all, thanks for your interesting presentation and lecture. It was really amazing. I have 2 questions, if I will be able to ask. So first question will be regarding your presentation. You mentioned that you are using indirect and direct revascularization procedures, yes? So as I saw in UpToDate, there is also another procedures. In another procedures, I saw that sometimes healthcare professionals also use combined method. If you use also combined method, and in which cases you use combined method. And also regarding that question, also I want to ask one more about endovascular embolization. In some kind of aneurysms which are associated to that moyamoya disease, some of the specialists also using that endovascular embolization. If you use in your practice that embolization. And I want to ask another question. As a medical student, I'm interested in your practice, what was the most difficult case in which you were a little bit confused to have differential diagnosis, and then maybe you diagnose that patient with moyamoya disease or with another disease, but you were thinking about that patient had moyamoya disease. So which diagnosis was the most difficult to have differential diagnosis with moyamoya disease? Thanks again, and hopefully you will understand my questions. Otherwise, I can continue and I can repeat more.
So let's start with the endovascular. Thanks. So the endovascular, if you have a rupture and you perform angiography, usually it's a false aneurysm. But an endovascular embolization in the acute situation is certainly a good way to treat that aneurysm, because they are usually in the collaterals inside the brain. So they are certainly not surgical cases. Then the combined thing, as I mentioned, for most of our cases, we are using the combined approaches for the adults, this MIS, minimal invasive technique, and for the pediatrics, the peritoneal approach. But it's usually combined, and then we see whether the bypass is doing better or whether the indirect is doing better. And the other question was the differential diagnosis for moyamoya. So in kids, you have a temporary M1 occlusion that can lead to stroke, which is which you have to know, because it might be mistaken as early moyamoya, but these occlusions then reopen and they don't need a bypass. This is the pediatric important differential diagnosis. And then sometimes we have very strong antigenic responses in moyamoya patients. And sometimes they even look like vascular malformations, like AVMs or so, this thick blush, or like tumors. So they should not be mistaken by AVMs or by, rarely also by tumors. I think these are the most important differential diagnosis that can mislead you.
Okay, thank you. And hopefully I will see you in Charité once in my life.
Pleasure. Always welcome. Yes. Everybody's welcome.
There is a question directly written to me, not to the public, and from Edmund, from CMC Vellore Hospital, India. And Edmund writes that, what is the clamping time for the bypass? If the first recipient vessel fails, what are the options?
The first question I've understood. The second question I did not understood. If
okay,
the first vessel failed,
copy and paste to the chat.
So the clipping, the transient clipping time for an STA anastomosis to M4 to a cortical branch depends on whether you are performing interrupted sutures or running sutures. If it's running sutures, it can be done below 10 minutes. If it's interrupted sutures, you are somewhere between 10 and 15 minutes. But it doesn't really make a difference, because you have, in such a distal territory, you have easily 20 or 30 minutes. And this is why the anastomosis STA M4 is usually a very safe anastomosis. If we perform anastomosis to M2 for aneurysms or for tumors, then temporary clipping time should not be longer than 20-25 minutes. We usually need between 15 and 20 minutes. It's a little bit more difficult in the depth of the Sylvian fissure. But for ischemia, temporary clipping is not an issue. And the second question is, if the first recipient vessel fails, okay, then I cut it. I coagulate the stump, I cut it, and then I look for another recipient vessel and I do another anastomosis. If you are very experienced, you can open the anastomosis up again and try to remove the clot or try to redo the anastomosis. However, if you are not experienced, then I would just cut, coagulate the stump, and do another anastomosis. And this is why it's important to always have some reserve. Always have a longer graft than the one you really need with some curves, because if the first fails, then you have enough bypass for another anastomosis.
Okay, thank you so much, Professor. And Shiv Mehmet Shan, would you like to ask something? Shiv Mehmet graduated from medical school 1 month ago and became a doctor young.
I don't have a question. I spoke with Professor Vajkoczy at the Roto meeting, and I'm just starting. Today I started my Doktorarbeit in Düsseldorf until I get my approbation. We will see.
Very good. Good luck for that.
Thank you.
And Professor Bektaş Açıkgöz, would you like to add something?
Thank you, Professor. It's a good, excellent speech. Thank you very much for underlying the importance of bypass surgery. Thank you very much.
I'm happy that you liked it.
I think the meeting is a worldwide meeting tonight.
Yeah.
Thank you very much.
Actually, there were 79 participants, and it was half and half Turkish participants, made of half and the other half consisting of international from many countries. And the speech took about one hour, and the discussion, question and answer part is more than half an hour. And it was a perfect lecture. Thank you very much. And I want to thank everyone who joined us today.
Thank you for having me. Bye-bye.
Bye-bye. Thank you.